Hello, I'm Dave Kading. Welcome to Eyecare's Lit, brought to you by Optometric Insights Media.
You're listening to Eyecare's Lit, where science meets the clinic. Hosted by Dr. David Kading, we break down the latest research, clinical studies, and real-world insights, turning complex data into practical care for today's eye doctors, from dry eye breakthroughs to myopia management and beyond. This is Eyecare's Lit, brought to you by Optometric Insights Media.
On today's episode, we're going to be decoding some of the biggest updates that we've seen in ocular surface science since 2017, and that's with DEWS 3 from the Tear Film and Ocular Surface Society. But before we get into the science, I want to stop and thank Beatrice for their support of this podcast through a non-restricted educational grant. If DEWS 2 gave us structure, then DEWS 3 gives us precision. It's not a revolution, it's more of an evolution, one that fine-tunes how we diagnose every dry eye patient that we see. I loved DEWS 2, and back in 2017 and 18 when I was digging into it, it really helped us understand some things in defining it. And it defined dry eye as a loss of tear film homeostasis accompanied by symptoms. But in 2025, DEWS 3 expanded that to include tear film and or the ocular surface. That small addition and or the ocular surface makes a little jump in wording, but a major shift. It recognizes that dry eye isn't just a tear film problem. We kind of got that from the homeostasis in the prior definition, but it really focuses more on the ecosystem imbalance involving the cornea, the conjunctiva, the glands, and an emphasis in 2025's tear film, the DEWS 3 is the neural pathway. So in short, the disease can begin in the tear film or in the tissue beneath it, and the clinician's job is to detect where that homeostasis is lost. DEWS 3 also streamlines how we begin the workup. So instead of choosing between DEQ5 or the full OSDI, which is kind of the discussion points in DEWS 2, there's now kind of a global standard, and that is the OSDI 6. And if you haven't checked it out, I would highly recommend you check out DEWS 6. It's quick, validated in multiple languages, and easy to integrate into digital or paper workflows. In this, a score of 4 or higher triggers us that we need to be doing further testing. And I like how it brings in lifestyle into the conversation with night driving and environmental concerns. So I would encourage you to look at it. The single questionnaire standard means that whether you're in Auckland or Boston or Seattle, you're speaking the same diagnostic language, and epidemiologists can finally compare data across countries. As we look to the future of systemizing our approach and understanding ocular surface disease from my practice to yours, by having these standardizations, my data will mean something to you, and your data will mean something to me. And then we can incorporate things into artificial intelligence and learn a little bit from each other. So after the symptoms are confirmed, DEWS 3 asks for just one positive sign for us to be diagnosing patients as having dry eye disease. So any one of the following: non-invasive tear breakup time under 10 seconds. Ideally, this would be repeatable. If non-invasive tear breakup time isn't available, fluorescein tear breakup time can be used, but obviously because it's more subjective, it's less ideal. So number one, non-invasive tear breakup time. Number two, tear film osmolarity greater than 308 in either eye, or if we see a difference greater than 8 between the eyes. And then ocular surface staining, greater than 5 corneal fluorescein or greater than 9 conjunctival lissom green spots. You can also include lid margin staining greater than 2 millimeters and 25% of the width. And that, this is the scientific information, but if you see staining that looks more than just a spot or two or three, that signals you need to be thinking of something. If you see that nasal or temporal conjunctival staining, probably need to be considering this is the diagnostic, but it's 9 conjunctival list of green spots, 5 fluorescein spots, lid margin staining greater than 2 millimeters and greater than 25% of the width. So if you see that lid wiper area, that lid margin staining, so that's staining, osmolarity, and then also looking at non-invasive tear break time. So a positive result there confirms dry eye when you combine it with OSDI 6. And that workflow moves from least to most invasive, preserving the tear film for each subsequent step. So DEWS 2 taught us to think in terms of evaporative and aqueous deficient. DEWS 3 moves beyond those boxes to a driver-based model. Now we identify the underlying etiological driver, tear film deficiencies, lipid, aqueous, or mucin glycocalyx, eyelid abnormalities, blink, closure problems, margin disorders, ocular surface abnormalities, consider neural, inflammatory, or structural changes. And, that can point to how we may go about with our treatments. Each driver, in fact, does directly give us a management pathway. Diagnostic and treatments are now intertwined. When you find the driver, you've already mapped the therapy according to DEWS 3. The new approach reframes diagnosis as part of the management. Instead of labeling a patient, we identify what's really breaking down in the homeostasis process, and then it gives us a target for that mechanism. This process a little more pragmatic. It's personalized, globally reproducible, so that what you're doing in Auckland or Sydney, I'm doing here in Seattle, and that helps with our modern ocular surface care needs to bring some unity to how we're treating. For clinicians, DEWS 3 means fewer redundant tests and clearer thresholds. For researchers, it means comparable global data. And for health systems, it defines the prevalence more accurately, guiding policy and resource allocations. And where I'm hopeful is it will be using artificial intelligence. Ultimately, standardization builds confidence among us practitioners, amongst researchers, and most importantly, amongst our patients. DEWS 3 also highlights something simple but vital. They talk about communication, and we're reminded to kind of explain the findings in more plain language, discussing lifestyle triggers, inviting the patient into the conversation. And I think that's key, for any discussion we have with our patient. So the essence of DEWS 3 goes from tear film to the ocular surface. What was multiple questionnaires, like one clear standard, from evaporative aqueous to more of the etiological drivers, from isolated diagnosis to integrative care. It's not just an evolution, it's like the alignment of things. And this dry eye diagnosis in 2025, and as we head into 2026, brings consistency, connectivity, and clinical actionability for us as practitioners. So, thank you for joining me for this episode of Eyecare's Lit. Thank you again to Beatrice for their non-restricted educational grant. I'm Dr. David Kading for Optometric Insights Media.